Welcome to the presentation regarding hypertension for Module 9, Nursing 150. These are all the factors that influence someone's blood pressure. Cardiac output is the amount of blood that is pumped out of the ventricle with each heartbeat. So that is going to influence how much pressure. And then the resistance that left ventricle has to push through. So that's the peripheral vascular resistance. So those two together is going to affect the blood pressure. And anything that increases this peripheral vascular resistance, heart rate or stroke volume, increases your blood pressure. So anything that causes a faster heart rate, anything that causes vasoconstriction, other things would be volume overload would affect your cardiac output. So just think about all those things that could affect your peripheral vascular resistance and your cardiac output. So this is just a review of the classifications of hypertension. We all know normal hypertension is 120/80. We start looking at people with pre-hypertension that have more than one blood pressure reading of a systolic of 120 to 139 and a diastolic of 80 to 89. And that is more than one reading, because sometimes, a patient will come in and have a lot of things going on and they can have that one higher blood pressure. But we have to make sure that it's more than one blood pressure reading that it consistently reads this way. The important thing is to know someone's baseline. A lot of times someone's baseline is way below 120/80. They might be somebody that runs like 100/70, 100/60. Just know their baseline. So basically the point of that is if somebody is reading 130/80 that normally reads 100/70, then that is a concern as well. But like I said, it has to be more than one reading that reads that higher level. And then these are the different stages. Once they get a systolic greater than 160 or a diastolic greater than 100, then that's a stage 2, and that's a pretty severe hypertension. There's lots of tables in your book that explains the etiology of hypertension. On page 776, it talks about the classifications of normal pre-hypertension, stage 1 and stage 2. And then there's a table on 777 that talks about the etiology of essential and secondary hypertension, is what we'll talk about in the next slide as well. Primary is also known as essential hypertension. It's a sustained blood pressure elevation in patients. It can result in vital organ damage because it damages the arterioles and it thickens it. It causes damage to the blood vessels. It's basically primary or essential hypertension is caused by modifiable factors, risk factors, and that's overweight, smoking, high lipids, the diet, excessive sodium and caffeine in the diet, physical inactivity, excessive alcohol intake, continuous stress. Again, remember, I think we talked about stress is a really thing that gets kind of looked over, but if someone has a very stressful lifestyle, it can lead to hypertension that is uncontrolled. There's other non-modifiable risk factors that can lead to essential hypertension, and that is a family history, your ethnicity. African Americans do have a higher incidence of hypertension, and just older age puts you at risk for hypertension, especially women, again, who have reached menopause. They've lost their estrogen stores that protects them, so they're more at risk. Secondary hypertension is usually a secondary cause, so it's related to somebody who has maybe a kidney disease. Kidney disease that causes stenosed arteries in the kidneys can cause secondary hypertension. It also can be due to a adrenal problem. Remember, we talked about all the ways that the kidneys assist in regulation of the blood pressure, and the adrenals do as well. So if there's any kind of a problem like Cushing's with the adrenals, that can cause a secondary hypertension. There's a few drugs that can also cause secondary hypertension. Estrogen, glucocorticoids, cyclosporin, erythropoietin. Estrogen-containing oral contraceptives are also known to cause secondary hypertension in women. So typically people do not have signs and symptoms of hypertension unless it's pretty severe. So somebody that's running 150/90, they may never know. They have no symptoms. So that's why it's a little tricky to treat. And that's why we do screenings. And maybe somebody gets their blood pressure checked the first time and they have a blood pressure of 140/88. They're looking a little pre-hypertension. They're overweight. They have diabetes. They have a lot of stress in their life. So if they have they're looking pre-hypertensive, they have some risk factors. They'll continue to monitor their blood pressure and try to do some modifications in their lifestyle to try to bring it down and get it back to normal before they will aggressively treat it with medications. So that's the way we start. It's sort of similar to diabetes type 2. We want to treat it with things that it can be lifestyle changes first. Lose weight, decrease the stress, change your diet, limit alcohol intake, try to stop smoking, things like that first. Once someone gets a severe hypertension, they will start to have symptoms: headaches, dizziness, fainting, facial flushing. It's that pressure. They'll start to show signs and symptoms of it. So typically when they show these signs and symptoms, their blood pressure is pretty high and pretty severe. Really don't have any labs to detect a primary hypertension, but these would be related to a secondary hypertension. BUN levels to kind of help us determine somebody's fluid status. Then the creatinine is going to indicate any kind of underlying kidney issue. And urinary tests can tell us if there's protein in the urine. It also can be an indicator of any kind of an adrenal problem because they could have the presence of catecholamines, corticosteroids or ketones or anything like that in their urine could be an indicator of an adrenal problem. Again, prevention is the key, as in most diseases. Lifestyle changes, if it's a primary hypertension, they have to lose some weight, if they're overweight, no smoking, try to limit caffeine, decrease the stress in their life, do some things that they like to do, help them, support them through maybe getting some hobbies that helps them relax, things like that, because if they continue to have the hypertension, it can be detrimental and can lead to a lot of very serious complications. Some lifestyle changes recommended in your book include restrict sodium intake in the diet, reduce weight, use alcohol sparingly, exercise 5 days a week, use relaxation techniques to decrease stress, avoid tobacco and caffeine. Drug therapy. There's lots of medications out there for lowering of blood pressure. Diuretic therapy is typically the first line of treatment. They usually will start out with a thiazide diuretic, which is usually a mild diuretic to help decrease the blood volume and lower the blood pressure that way. It's usually a pretty benign way of treating a blood pressure that doesn't cause a lot of side effects. We'll discuss a little bit more about drug therapy in the next slide. So diuretics, we mentioned the thiazide diuretics. Hydrochlorothiazide is the most common one. There are a few side effects, but like I said, it's typically a pretty safe medication. They're very, very cost effective, and they usually work pretty well for somebody who has, a stage 1 hypertension. The major side effects is a decreased libido in men, and used with caution in patients with diabetes. They can interfere with the serum glucose level. And also with a patient with gout, you have to use caution because it can modify their sodium levels. Loop diuretics are another diuretic that can be utilized for the treatment of hypertension. Lasix or furosemide is the most common that we typically see. You do have to use some caution with that drug, especially in older adults, because they can lead to dehydration, and orthostatic hypotension, which is when they stand up quickly, they drop their pressure. And that's typically something to look for in the older adult, like 70 and older. There's potassium-sparing diuretics, such as spirulactone. And those drugs are pretty safe as well, but you do have to, those spare the potassium level, so it spares loss of potassium with the fluid. So if somebody has a high potassium level, you have to use that with caution. And the loop diuretics are just the opposite. The loop diuretics, when they take the fluid out, the blood volume out, they also take potassium with it. So a patient on a loop diuretic such as furosemide can have a risk for low potassium levels, so they typically have to be on a potassium supplement. So angiotensin converting enzyme inhibitors are the ACE inhibitors, and they work in the area of the kidney where the angiotensin renin aldosterone conversion system works to regulate fluid and vasoconstriction. So basically it inhibits the action that occurs in the kidneys to vasoconstrict the vessels and to hold on to fluid. So it inhibits this action, therefore lowering the blood pressure. Angiotensin II receptor antagonists work very, very similar to the ACE inhibitors, and they just work a little bit different in that area, in that mechanism of action. The important thing to understand is we typically start out with the ACEs, and then if they get too many side effects of the ACEs, which one of the major ones is a very obnoxious cough, then it's very nagging, and a lot of times it can affect their life because it keeps them awake and things like that. So if that occurs with the ACE inhibitors, they'll put them on an ARB because they are very similar, but there's no cough with the ARB. ACE inhibitors are also famous for causing orthostatic hypotension, especially in the elderly, especially with the first few doses. So it's used with caution in older patients. And they have to monitor their blood pressure with all of these meds. They have to make sure that we're not giving them too much to where we make their blood pressures too low. So it's something as an educator that you would have to do about these meds, teach them to take their blood pressure and their heart rate. Calcium channel blockers are typically pretty safe meds. Again, they do have to monitor their blood pressure and heart rate just to make sure they're not getting too much of the medication, especially in the elderly. And then they do have to avoid grapefruit juice. There's a lot of meds that you have to avoid grapefruit juice in order, because it can enhance the action of it. I don't know a whole lot of people that do drink grapefruit juice, but if they do, they need to just take it in very, very, very small amounts. So this is just more of a slide that just kind of reviews the mechanism of calcium channel blockers and gives you a couple of examples of calcium channel blockers. And again, just a review of the mechanism of action of each of these drugs. So beta blockers, one thing I did not mention, and this slide here mentions, is the ischemic heart disease. It's the drug of choice. That is that patient that has high blood pressure, that has had a myocardial infarction, and has a diseased heart. So they like this because, again, if you think about what needs to happen with a patient that has a poor heart muscle, we don't want it to have to work very hard because it's diseased. So it controls we want to control that hypertension because we don't want that diseased heart to have to push very hard. So the betas keep the heart nice and chill, keep it, just pumping, and helps it to have a better push, a more effective push, and keeps them nice and good and controlled hypertension. So it's a good treatment for a patient with ischemic heart disease. This concludes the presentation regarding hypertension for Module 9, Nursing 150. The other thing that I would recommend reviewing is nursing care and nursing education. That is one of the biggest things as far as hypertension, especially primary hypertension. We have to teach our patients lots of different things. The fact that if they have been determined that they need to take medication for their hypertension, they need to always take it. Because what happens, again, like in some other disorders, once they feel better, they think they can quit taking it. But they need to understand that once they've been diagnosed with hypertension, they typically, for the most part, most patients have to continue to take it for the rest of their life. So they just need to understand that. And there's, again, like I said, there's lots of side effects to these meds, so they might not want to take it. And they might try to stop taking it, and that can get them into trouble. So it's going to take a lot of education and a lot of understanding and a lot of support to get them through taking these meds. The other thing is there is an instance where somebody can have a hypertensive crisis, and that is where they get that profound hypertension that we can't get their blood pressure down. So they typically hospitalize them and give them IV meds to lower their blood pressure, and that's because it works faster. We need to get their blood pressure down. If somebody has a profound hypertension, I'm talking like 180 over 100, if they continue to run that high, they could absolutely have a stroke. And that is like if one of the arteries in the brain gets so much pressure that it could actually, if there's a compromised vessel in the brain, it could actually bust open from all the pressure, and that would be a hemorrhagic stroke, and that could be detrimental to the patient. So that's just a situation where we would have to be much more aggressive. There's a table on page 784 that talks about care of a patient with a hypertensive crisis. So just review that just to be understanding of how aggressive we might have to treat that patient. And just review nursing care of a patient with hypertension. Talks about diet control, weight control, things that we can do to support them through that.